Hello, welcome to telemedicine. I'm really excited you're here, and I wanted to create this video as a way to give you an overview into telemedicine. There's going to be a lot of videos and articles within the course, but this particular presentation was put together as a way to allow and educate the various stakeholders in a healthcare setting about the generalities and the overall framework of telemedicine. So I'm hopeful it'll be interesting to you. Give me a moment while I share my screen and move into that area of the recording. One moment, please. Okay, I'm going to share my screen and we are going to get started. So Telehealth 101. So these are the basics. There's always more to it, but this hopefully will ground you. Hopefully it'll advance. Okay, we're going to talk about just an overview of telemedicine, the kind of services that telemedicine includes, why telemedicine is important to population health management, payment methodology, and I may or may not go over some of the video visit specifics, but that is included in this presentation. So let's just do a quick overview. There's a variety of terms that are floating around: telehealth, telemedicine, mHealth, and I wanted to just clear this up right away. Telehealth is basically the overarching umbrella that includes telemedicine. Telemedicine is a subset of telehealth, and mHealth is also a subset of telehealth. Telehealth includes everything from administrators creating a communication link to other facilities, or educating the public. Telemedicine is specifically regarding sort of clinicians to clinicians or clinician to patient communication. mHealth really is just about it being conducted on a wireless basis. So, and you may encounter some of the others. What I found just anecdotally is that when it comes to Google searches and people's understanding, telemedicine seems to be a little bit stickier than telehealth in terms of people's use of the term. So you can see here just a graphical representation. So I did this a few years ago, but the compound annual growth rate just continues to go up, especially globally. This is not just based on services, but also hardware, software, and services. So it's growing. I'm sure this is why the class is so popular. There's a lot going on in telemedicine. And I think the key that a lot of people, and I've discovered this myself, I worked at Banner, Dignity, CEP America, variety of rural entities, as well as one of the technology providers. Everybody seems to promote and or approach telemedicine from one angle. If they're a clinician, they're excited about the clinical impact. If they're technologists, they typically go in through a purchase of a technology platform. But really, the reason why telehealth has had such a challenging time getting going is not just because of the reimbursement, which we'll go into in a little bit, but also because of the complexity. Telemedicine or telehealth has a significant operational component, legal components, and financial components, as well as the technology and the clinical. And what can happen is, even if you have the clinical and the technology on board, if the legal department isn't willing to sign off, if the finance people don't understand the financial benefit of doing it, and if operationally you can't get it going, then it's a program that will be paused or stopped altogether. So we're going to discuss all of that in this class. That was always my preference. So telehealth services, if you look at a spectrum of services. There is continuous monitor. So first let's talk about the acute setting or hospital setting. In the acute or hospital setting, you've got very little variability in terms of hardware, software. Typically, an organization will purchase a platform for the entire enterprise or certainly for a particular area of medical expertise. So that's exactly the case in continuous monitoring. EICU, which is a Philips product, there's products for the NICU, and that's a pretty powerful use of telemedicine, and we'll go into more details and you'll learn more about it. The next area I talk about is patient to consumer, and those are things like telestroke and telepsych, where the patient presents in an emergency department, a doctor there, the emergency room doctor calls a stroke neurologist. The two physicians correspond via the video, but the consumer is also on board so that the distant physician can actually provide can conduct an examination. Then you have just the physician-to-physician consults, telepathology, teleradiology. Sometimes you'll have surgeons in a surgical suite, and then you'll have a sample sent to the pathologist, and over using technology, the pathologist can actually weigh in to make sure the margins are clear, et cetera. So that's another use. And then also more and more people are using medical education in the acute environment as a telemedicine functionality with grand rounds, tumor boards, et cetera. Very powerful way to use the technology and telemedicine functionality. So in the ambulatory environment, you have, for example, a medical education, but it's more dispersed. So from one center off to many. Physician to physician consults and physician to consumer consults similar, but usually it's a hub hospital out to a spoke rural or less complex facility. A community hospital as opposed to a quaternary facility. And then patient to consumer directly, which a lot of people, that's where they think telemedicine is, where you've got a non-emergent situation and a physician is available on your screen to diagnose and or treat. And then finally, home monitoring. More and more the remote home monitoring, especially addressing complex chronic patients post-discharge to reduce admissions. It's just it's a powerful tool, and Medicare has been creating some special reimbursement around it. So it's very, very powerful. So here's the entire spectrum you can see just in one graphic. So who cares about telehealth? You know, the telehealth can be championed by a lot of different stakeholders within the healthcare systems. Patients can be excited about it, providers, a hospital system, skilled nursing facility, all of them are stakeholders in telehealth and can actually be the initiator of a telemedicine program or project. The ones that care about population health, which is a cost-driven, population health is a way to address the costs of a population. We'll talk a little bit about the triple aim, et cetera, but the government cares because they're one of the largest payers. Accountable care organizations, employers, insurers, all care about population health because it's really about how do we improve the treatment and reduce the costs and improve the patient experience, which is essentially the triple aim. Okay. So examples of telehealth use can include primary care, specialist referral services, acute remote patient monitoring, ambulatory patient monitoring, medical education. And these are some videos which you'll see later in your that are listed independently within Blackboard. You'll see some examples of the specialty care, telehealth use in a acute environment, remote patient monitoring, how it's designed. The important thing to consider with all of the programs is that while there's a gee whiz, isn't that cool component, it's really important to also realize that you need to create a criteria for evaluating the impact of the solution or the program. So for example, is it just that you can reduce the number of hospitalizations? I mean, is it just convenience, or can you reduce number of hospitalizations? Can you reduce readmissions? Can you reduce mortality, or even the length of a hospitalization? All of those are worthy goals of telemedicine, and by creating data around that, you can sell the program, because a lot of the programs aren't revenue producing, but they are cost avoidance. They do avoid costs for hospitals, and so we'll get into that more in a second. You'll see an example of medical education with the Project Echo. So just population health management, let's just talk about that. Telemedicine in the use of population health management means that the provider is going to benefit by use of telemedicine. More referrals, more transfers, revenue, consults, convenience, increased availability, develop and extend the expertise, and also offer more information to the provider. So these are all of the things that will benefit the physician, especially when we're talking about population health management. The clinical value with telemedicine is that organizations can see more patients with telemedicine. There are opinions and, I believe, solid evidence to show that patients will be more compliant if they know that somebody's checking in on them, and especially given how many patients have a hard time coming in from rural areas, and even in areas within an urban setting but may not have the transportation, compliance is improved with telemedicine. And it also offers patients the opportunity to direct their own care. There's not been any difference found in care efficacy. I think there's one study that shows a difference. It had to do with antibiotic over prescribing antibiotics. And the other thing is that as people get more comfortable with technology, this provides them with another channel for communication with their physician. So more and more organizations are creating a market alignment. You'll see large health systems that will have urgent care, will have a partnership with rehab, skilled nursing, physicians. So we'll talk more about this, but the whole ecosystem of healthcare there's an increased pressure to align the patient with the location that's most likely to offer the most care, the best care, not too much care and not enough care, but the right amount of care. And it's sort of a flattening of the curve of patient care. And we just talked about what population health is. It's about the triple aim: better care, lower cost, better population health. And some of the ways to do that is monitoring complex chronic patients. We've talked about remote patient monitoring. Some organizations like Banner are using it for people who are immediately discharged and they may have congestive heart failure or acute myocardial infarction. Those are also monitored by Medicare, so that if somebody is readmitted to the hospital within 30 days, there is a financial penalty. So remote monitoring can help reduce those bounce back patients. Long-term complex chronic patients can be monitored, vulnerable populations, and right now a lot of the reimbursement, although it's changing, some of it's now you can have it at home and get reimbursed, but for the most part, you've had to be in a skilled nursing facility. But there are programs around the country that are focused on, well, what if we were to bring some of this remote patient monitoring into community centers or places where the elder population will be willing to go and perhaps offer some, their arm for blood pressure or their blood for a diabetic check. This is another example of remote patient monitoring. So we're going to talk a little bit about cost avoidance, which is the big push in telemedicine because it hasn't been a revenue generator so very much. So one of the reasons why American Well, Doctor on Demand, some of the others, MD Live, have been so successful financially in the investment markets is because of this particular function. So when you've got self-employed insurers, so organizations with large healthcare costs, organizations like IBM or think of any of the Fortune 500, they self-insure. They don't go through an insurance company. So for them, they are allowed to dictate the terms of a patient's options. And anything that they can do to shave off costs will benefit the company and their constituency, the employees, as well as eventually their customers, because they can not increase their prices. So what was happening is people were going to the emergency department on the weekends or at night when they couldn't get into their primary care provider. They were going to urgent care or the PCP. But if those costs could be avoided by instead intervening a telemedicine visit, then you could save anywhere from $79 to $1,427 per visit. So that really adds up. And these are all, based on national numbers. So you can see here, this is the care continuum, and there's pressure on it. Telehealth, retail clinics, etc. Just the cost gets higher by adding the two areas to the left of primary care physician. It's continuing to put pressure on the cost. So that is essentially a cost avoidance argument. And here's the other thing: a lot of people. This is a advisory group slide. There is a preference with consumers. They feel as they are increasingly comfortable with technology and they have more stake in the game financially with large deductibles, they are saying, I know that I can direct some of my care and I want to shop based on convenience and cost. Whereas in the past, you would just go to wherever and you really didn't have much knowledge of the healthcare costs. It was all sort of done on the back end. But now people are saying, well, if I can spend $40 or $50 on my office visit as opposed to $134, well, gosh, I'd rather just do the lower cost visit. So this is another key aspect of driving the direct-to-consumer telemedicine. The other thing that's interesting is that 5% of the patient population in healthcare generates 60% of the costs. So what you'll find is that organizations, especially in the acute care environment, that can reduce the cost of those 5% by reducing hospitalization lengths, by improving outcomes, by reducing the number of hospitalizations, it's beneficial to all involved. We talked a little bit about remote patient monitoring already. I'm going to just go very high level on the payment methodology. Essentially, there's multiple buckets of payer sources: Medicare, Medicaid, private payers. When I say private payers, I'm talking about insurance, which includes the exchange. There's obviously more payer sources than this. There's the VA and cash pay patients. But I'm specifically talking about the ones that have criteria surrounding telemedicine. So there's 5 factors associated with reimbursement: the type of telehealth transaction, geography, site type, eligible practitioners, and the coding. So there's a couple of types of telehealth transactions: asynchronous, which is also called store and forward, which is similar to, for example, let's say you take a picture of a mole on your arm and you send it off to a dermatologist to view whether or not it looks like it needs to be further checked out. That's an asynchronous. Radiology, somebody who views your CAT scan without you knowing it. Those are mostly unbillable, although there are some exceptions. Hawaii and Alaska have had some special programs that Medicare have been willing to pay for. Synchronous is mostly billable, and that's really real live. So patient to doctor in real life requires a webcam use, and that's mostly a billable transaction with some exceptions. And then there's also remote monitoring and acute monitoring. Most of those are not billable. Up until recently, and I think it's still this way, you can't get reimbursed for Medicare unless you are in a rural setting. So if a person in a rural hospital uses, the emergency department uses a telemedicine cart to gain the consultation services of a physician in an urban setting, then there's reimbursement. This is more Arizona-centric, and every state, and this is the challenge, is that every state has different Medicaid rules and different legal requirements associated with physician use of telemedicine. So, so if you are going to promote it in your state, or with Indian Health Services, you need to really investigate what the requirements are to be reimbursed or to be compensated for a telemedicine visit. In this case, Medicare has a different site type than Medicaid. They have like Medicare's a little bit wider. They include FQHCs, renal dialysis centers, where in Arizona, for example, they'll include IHS and tribal governed facilities, but they don't include dialysis. So this is the challenge. Eligible practitioners, also a difference. Medicare is pretty strict. You have these 6 areas. Medicaid, very broad in Arizona, that is. Also, there's special coding, GT and GQ modifiers. There's a new remote patient monitoring. I think there's actually a few more codes. So it all has to be coded as well. So this is why telemedicine has been so challenging. This gives you an overview as to why people are intrigued by it, but the challenge of billing for it. And in the class, we'll get into all the details associated with operationalizing a telemedicine program and project, as well as looking at the benefits. So thank you so much, and I look forward to having you in class.